Good morning, Your Excellencies, ladies and gentlemen. Welcome to the live session of 31st TCTAP 2026. My name is Mintz. It is my great pleasure to grab the microphone as your MC today. It is a privilege to open today's program in the presence of so many distinguished specialists whose work continues to advance the field of cardiovascular medicine. To kick off our program, we are delighted to present a live case transmission from Asan Medical Center in Seoul, an institution widely recognized for its clinical excellence and its long-standing contribution to TCTAP. This session offers a valuable opportunity to observe decision-making and technique as they unfold in real time. So to guide us through this opening session, so please join me in welcoming our moderators. We are joined by moderators Dr. Spencer B. King and Dr. Seung-Jung Park, and they are joined by an exceptional panel for expert discussion, Dr. Sripal Bangalore, Adrian P. Banning, David J. Cohen, William F. Fearon, Myeong-Ki, Gary S. Mintz, Duk-Woo Park, Pieter Smits, David Paul Taggart, and Dr. Alan C. Yeung. Thank you very much for joining us today. Now we'd like to begin the first session. So I'd like to hand off the microphone to our moderator. Dr. Park, would you please start?
Welcome, everyone. This is a great pleasure to be here once again in Seoul at this fantastic meeting that's been going for 31 years. And I congratulate S.J. Park for his work and D.W. Park for taking this now, moving it forward. A lot of things happening in interventional cardiology. I reflect on the very beginning, and I'm reminded that whereas we found many solutions, the problems continue to remain, and I challenge all of you to keep focused on those problems, and I see from this program that that's the aim. So I'm delighted to be here once again and be included.
Thank you. Anyway, thank you, everybody. So it's really sorry forced, TCTAP meeting is. I'm very happy. So we want to start live cases as a first session from the Asan Medical Center. Dr. Do-Yoon, can you hear me?
Yes, I can hear you.
Okay,
Good morning.
Right. So would you explain that what were your cases and?
Good morning, everyone. And this is my honor to present our live case as a first live case in TCTAP 31st. I'm Dr. Do-Yoon, an operator, and Professor Han-Soo Park, and our senior fellow, Ki-hwan Kim, will join the procedure. And let us introduce our case. Dr. Kim, please.
Thank you for the introduction. I am a third-year cardiology fellow at Asan Medical Center. I will present today's case. A 68-year-old male presented with syncope after running. He also experienced chest pain or exertion. He had no significant past medical history. He was diagnosed with stable angina. His electrocardiogram showed normal sinus rhythm. His chest X-ray revealed no cardiomegaly or pulmonary edema. Severe calcium on the coronary CT. On CAG, the right coronary artery showed mild disease. However, on the left coronary artery, the left circumflex artery os showed severe stenosis. And proximal RAD also showed severe stenosis, and distal left main revealed severe stenosis involving the trifurcation disease. Today, our plan is to treat the left main bifurcation disease involving the distal left main, prox RAD, and proximal SOC. These patients belong to the angiography-guided left main PCI arm in the FATE-MAIN trial. Professor Kang, how think about the treatment strategy in this patient?
Yeah, thank you for your presentation. Let me summarize the patient. 68 male-year-old patient with exertional angina and syncope with a short brief CPR event. And the coronary angiography showed the intermediate distal left main bifurcation with a severe circumflex ostial disease and diffuse proximal LA disease. And the patient has some left main disease, and we decided to treat the patient's left main disease. And we are also conducting a FATE-MAIN randomized control trial, randomizing the patient with a left main disease by FFR-guided PCI decision versus angiography-guided PCI decision. Yeah. So the patient will undergo the angiography-guided PCI.
Do you randomize? Randomize?
Yes. The patient was randomized to angiography-guided PCI group. And in those situations, we treat all disease by the angiographic diameter stenosis guidance.
Spencer, meaning...
Can I ask a simple...
All right.
The patient presented with syncope. Are you seeing it's an angina equivalent?
I think they said he had angina too.
Yeah, angina,
Yeah, angina
too,
also
but his
prevalent.
primary symptom was
Yeah.
syncope.
Yeah.
Like,
Yes,
what are you doing
that's
for
right.
that?
Oh, we checked the arrhythmia workup and echo and treadmill test. And after that, there was no big arrhythmic event or echo abnormality. And the patient has some ongoing exertion angina. So he was referred to our hospital.
David, Taggart, good to see you. And so, all right, this is a candidate for surgery, still high syntax scores.
Yes, this patient would be an excellent candidate for bypass grafting with 3 very good left-sided targets. Can I ask you, what do you estimate the syntax score for this patient to be?
Do you?
The syntax score
Syntax
was the 31 for this patient.
everyone.
So just under severe.
What did you say?
It's 31 is the syntax score.
So it's
Yes.
just outside the high-risk score traditionally defined as a score above 33. So this is high intermediate disease. But this patient is 6 to 8, otherwise fit and well. And if you did cabbage on this patient, we know from the ART trial, 80% of these patients would be alive at 10 years and around 70% at 15 years. So in looking at what is the simplest, most straightforward, low-risk procedure for this patient that offers an excellent, durable survival outcome, I would have to be convinced the patient should not have bypass grafting. Obviously different within the confines of a randomized trial, I can accept that. But otherwise, I think the first option for this patient, certainly in many centres, would have been coronary bypass grafting. Thank you.
So David, what kind of grafts would you put in here? You obviously would use Lima and Remo and radio, or what would you do?
So I think I think you would use 2 mammary arteries, and possibly, depending on what FFR showed of how severe the lesion is in the intermediate, if it's severe, radial artery would be a good choice. If it's not severe, saphenous vein graft.
You don't like your own trial that said bilateral internal memories don't help? You don't.
No, he said
It's
bilateral.
your trial.
No, I said
No,
bilateral.
no, and I said you, but you don't agree with your own trial's results. You're advocating what your trial said not to do.
Yeah, I'm not sure every colleague would do bilateral mammary arteries, but for those interested in doing arteriografts, there would have to be a reason to convince yourself not to, and that would traditionally be an obese diabetic with bad lungs. And this patient doesn't have any of that. So the risk of 2 internal mammary arteries would be very low indeed.
You're saying it's no worse and might be better.
Correct.
So the highest index score over 30, whatever it is generated from lesions all over the place. And I don't know how much it applies in the left main. It seems like this is a almost isolated left main situation that you need to worry about. So it seems more interesting to concentrate on what kind of outcome you could achieve with intervention versus surgery in such a left main lesion.
All right. Anyway, in terms of syntax scores, that if you look at the isolated left main digit itself, is not pretty big, right? Less than 20 something, right? Usually, concomitant downstream disease, they are the multivessel disease. Look at this, it's big diagonal branch, proxated diffuse disease. Those characteristics would be added high, syntax scores. Anyway, main itself is not a big deal. Anyway, the Fearon main study is based on the I'm sorry, David. Main disease is not surgical disease anymore. It's just published data, that optimal study, IBUS guided, angio guided. Anyway, they compare with PCI versus PCI something. And so I don't believe it's all the main cases to be candidate for PCI. However, maybe 60, 70% of a main disease would be candidate for PCI, just like
But Dr. Park, very briefly, your own studies, main compare in particular, showed a very different outcome from left main, which is true osteal in mid-shaft, from those bifurcation lesions. You showed there was much higher rate of restenosis with true bifurcation disease at the left main. So I think there's a difference between true osteal mid-shaft without additional bifurcation disease and bifurcation disease. And that's what the main compare registry showed very clearly.
I'm interested in the structure of this trial, which is between angiography and physiology. My center, I would have a hard time enrolling for this because everyone wants to do IVUS. What's the rationale of not including imaging in this particular study?
All right. Any big studies, angiographic stenosis would be more than 80% maybe matched with the positive FFI, right? Not 50% anymore, right? However, main disease is still 50% angiographic stenosis would be related to ischemia. The reason why LAD circumflex large jeopardy area. So, however, we don't believe still 50% narrowing is really, related with ischemia. And so the reason why you're going to do the FFR, guided main evaluation, sometimes, save the stand, save the,
But in this calcified left main condition, you don't think the IVUS contributes to the planning for the type procedure? How does it?
Maybe they're still allowed to. Are you allowed to use IVUS? Or it doesn't say anything about IVUS. It just says you have to use physiology. But maybe they still can use IVUS.
To guide which
Actually, procedure is guided by IVUS.
I mean, I'm looking at this.
In both groups.
Both groups get IVUS. Okay.
I'm trying to think, where would you put the FFR wire to accurately assess the left main, independent of this?
Can't. There's no clear path, right? You're gonna find out
In the patient with just isolated left main disease, we put the wire, the distal LAD, and check again in the proximal LAD. And if the patient has the downstream disease or the tandem disease in left main and LAD, we treat the LAD first by the FFR guidance, and then check the left main gradient again.
But if you were going to put the wire in the LAD in this patient, you've effectively excluded the circumflex anyway, because that's the most severe stenosis. So I'm basically trying to say, how are you going to use, how would you use physiology to assess the severity of this left main? And I don't think it's so easy. Bill?
Yeah. It's very complex part.
Okay, we will discuss. All right. Okay, we will discuss in the next case. Is Dr. Kang, you don't have any time to do the procedures.
Yeah, okay. Yeah. And
Just
we
I would you do
actually,
that. Just
yeah.
proceed.
will advance the procedure, and the patient has the distal left main and circumflex ostial significant angiographic stenosis, and we decide to treat both with the distal left main bifurcation, and the procedure will be guided by the IVUS. And we check the IVUS from the LAD and circumflex. Can you please play the IVUS pullback? This is the pullback from LAD. LAD has a diffuse stenosis, mainly in the mid-LAD and left main bifurcation. And here is the mid-LAD stenosis that shows calcification, and the septal branch just came in. And proximal LAD is relatively preserved. And this is the disease from the connecting to the left main, distal left main. Vessel size is more than 3.5. And here is the left main bifurcation. Here, distal left main here. You can see that the very high RI came in, and then circumflex came in from 9 o'clock in this image. And can you play the circumflex?
Yeah, but what was the MLA in the left main?
Can you please check, turn on the left LAD again? Yes, I'm sorry. And can you please measure the MLA of the distal left main bifurcation? More proximal. Here, RI comes in, and you see circumflex ostium stop. Yeah.
A little more.
Yeah.
This is really the LAD. Sorry. More proximal, please.
This is LAD ostium. Yeah. And let's move to the more proximal. Proximal. Yeah, here. Just a bit more distal. More distal. More distal.
So this is illustrating how even in an experienced laboratory, just picking out the distal left main to measure is not so straightforward.
Yeah.
It's smaller than this.
Kang, Dr. Kang.
Yes.
All right. This is basically we have some controversial issues. You choose the angio guided, right? We discussed a lot, and so I was findings we learn a lot from that one. However, I was finding that cannot influence treat or not treat in terms of
That's right.
How to do concern something like that. You don't have any idea about the IBUS, and just based on the angiographic findings, LAD disease, circumflex disease, the minimal, intermediate artery disease. How would you do that by angiographic, findings?
By angiographic guidance, I would treat the left main to covering the proximal LAD lesions, because the mid LAD you can see them more than about 70% stenosis at the septal branch just opening, and I've also showed the severe stenosis. And also, I will treat the ostium of the circumflex because it has the significant stenosis plus, and the very high risk of the pinching or the stenosis after the treating the left main.
Mm-hmm.
So actually my plan is to open the circumflex ostium and treat with the from two-stent strategy to avoid the adverse the stent-related event, and then cover left main to LAD.
Okay, well, so IBUS examination is not mandatory in POSAM. Anyways, we can do that. However, just want to gathering the data from that. Okay.
And actually, I did the pre-dilation with a 2.5 and left main with a 3.5 NC, and then we begin to treat the circumflex ostium. With some crush stenting, a front crush stenting to open the circumflex ostium safely. And this is a 3.25 by 12 millimeter balloon because the circumflex region is very short and the proximal region is calcified, but well opened with NC balloons. And the balloon to LAD is 3.5 for covering the prox LAD.
Would you ever consider using, a DES in the LAD and just a DCB in the circumflex after adequate pretreatment? Again, in the U.S., we're just starting to get here, but the rest of the world has been here for a while, and I'm curious, because again, we know the circumflex ostium is such a tough area for stents.
Yeah, that's a very good idea, and actually we are trying to do more with open the circumflex ostium with the DCB. And there was one trial that covers the KISS trial and also the same design for KISS for the left main I-KISS trial is ongoing, but we still do not have any concrete data. And in our registry data, the patient with a block burden at left circumflex ostium more than 50% and the narrow angle 120 degree has the high risk of the stenosis after crossover stenting, and the patient experienced some periprosthetic MI or unstable angina or unstable vital sign event. So in those patients, we are trying to open it with a front two stent for patient safety, procedural safety. And if the angle is not narrow and the plaque burden is not high on the circumflex ostium, and we are trying more and more with the crossover with the DCB, the balloon angioplasty for circumflex ostium. But there is no concrete data because we have some data for DCB for side branch, but circumflex side branch is different from non-left main bifurcation. So we are gathering more and more data about that. Test two.
This is a pretty
Test two.
it's a pretty big circumflex.
It's definitely a 3.5.
Test two.
Yeah, so I would think
What
that
size?
But it's pretty
This
focal.
is 3.25 stand, and I already opened it with the 3.25 NC tested.
Okay.
It was very calcified at the ostium. Yeah.
Did you IVUS
I
the
want
intermediate branch at all? Did you do IVUS on the?
Yeah, no, I did not
Okay.
check the IVUS. The ostium was very large and enough big, and the LAD and circle back, and the angiographically also good. So I will just keep it alone.
Okay.
Test.
Yeah.
Okay. So, Omina.
You want to do mini crush, right?
Yeah, nano crush. I think.
Yeah.
All right.
Deflation. Okay. 12. 14.
High pressure.
16.
You said this is
To
3.5
open
or
the circumflex,
3.25?
it's 3.25 stem balloon. But still, you can see that the indentation of the circumflex ostium with some calcification, deflation. And I will open more with the NC balloon before crushing to utilize the circumflex ostium, getting bigger before crushing, and make it easier the subsequent procedures. 3.25 NC, please.
Yeah, I also tend to use cutting balloons here, especially in the ostium, high pressure cutting balloons, undersized by 0.5.
That's a very good idea. Yeah, but actually the IVUS could not easily pass, and the 2.5 NC could not easily pass the circumflex ostium. So actually, I gave up to pass the cutting balloon to circumflex ostium. It's very angled.
Sripal, would you think
And
about
calcified.
a shockwave also, or not really?
Yeah, I think
Oh yeah, it will be a
will
very good idea.
That's
Yeah.
a consideration.
Yeah,
I mean, you
also
can clearly
consider-
see underneath that it did not expand.
But,
Yeah.
but the counter argument is that the calcium is already in pieces. This is not a solid arc of calcium.
It's not a 360.
Yeah.
No.
And it's not even,
Deflection.
even if it was 360, it's already in chunks.
I guess, yeah. I don't think we saw the circ. We never saw the circ.
No, we never saw the circ.
Deflation.
But he did.
But
20.
We actually had a quick peek of it, David, and I think that the calcium is mostly in the left main rather than the ostium.
Yeah, I agree with you.
Yeah. Deflation. Yes,
looks
I agree
inflated
to Mintz's opinion. The calcification is at the left main. And it's flux LAD and left main, not circumflex ostium.
How
But still,
high a
it,
pressure were you applying there? What was
yeah.
the pressure
It was 28.
for
28.
5 seconds?
Yeah, Spencer and I were talking about duration of balloon inflations this morning,
Test.
and how it's become a lost strategy, let's call it.
Wow.
Nominal.
Okay. Limit. How would you do that?
Yeah, actually, that's very important for calcified region for long-term dilation. But I'm a bit nervous, so I forgot it. I will do more for the left main deflation.
What size? 35?
And it's 3.5, 20. And
Crush. Balloon crush force.
yeah,
Right.
for
Great.
Columbus, yes, you can still see some indentation, and patient has chest pain. Deflation. 네, 조금 아파요. I'll try once more to fully open the calcification. Okay, vital sign stable, 18, 20, 22, 24. Deflation. Yeah. So patient has the chest pain when I close the left main. Shall we check the angio for audience? Yeah, angio. You can see the dissection of the calcium. And RI is well open.
Are you gonna
And I
cover the
restrict.
one stent, long stent from the LAD to the main?
Yes, I want to use the one long stent to cover the proximal to mid region with just one. We have nowadays we have a long stent like 48. So this is the 3.5 by 48 stent balloon. Actually, the distal size is 3.25 distal landing zone. So 3 would be more safe selection. However, the 3.0 stent just dilates up to 3.75, so it's small for the left main. So I selected 3.5, and we dilate a little bit smaller, and then further dilated left main.
So Dr. Kang, do you need the wire and circumflex because you get?
Oh, and I will
Push,
remove
yeah.
it.
Yes, I always hated to be.
to really
Oh,
push
yeah,
that hard.
yeah. Thanks
a
so
lot
much.
of calcium.
Yeah.
and Sometimes
Definitely,
you get
I
surprised you
will
cannot
remove
pull the wire easily,
Yeah.
and there's no need for it at this point.
Wrestling with that. There you go.
Good.
Trying
You know.
this.
Nice to have big guys. Drawing from
How
the
big is
groin
that groin? Is that a
compared to a
guess it's
6 French
an eight.
radio?
It's a different kind of guide extension.
just the old-fashioned guide extension?
Test.
Just over. A little bit further.
Okay, test again.
Looks
Okay,
good.
all the
Distal
region is
enough. Yeah.
covered. And I will check the left main also again. The left main shaft was the mildly diseased, so I do not need to cover all the left main. Test. Okay.
Okay.
7.
All right.
Yeah. Yeah. Distal left main, distal LAD was not so large, so I will open a little bit smaller, and then we'll cover with a higher pressure layer. 8, 9. Okay. Deflation.
Still on the expansion of the distal part of
Yes, you can see the under expansion. Yeah.
We need a Sripal. Okay.
And no, I will do more. With moving the balloon inside. Okay, 12. This is nominal balloon. Yeah. 13. Okay. Deflation. it's dilated, but still you can see some under-expansions at distal. So we need more the post-dilation to optimize the standing expansion.
So,
And I will use the 3.5 NC balloon.
Dr. Kang, you have to do the angio-guided NC balloon, high pressure inflation,
Yeah.
right? All right. All right. So after then, we want to move to the second room, and we will be back. Would you go back to the second room?
Okay, I will finish my work.
Jung-Min Ahn. Okay. Jung-Min, can you hear
Yes,
me?
I can hear you. Good morning. Yes, good morning,
right.
Dr. Bak. Good morning, Dr. King.
All right.
So we prepared another live demonstration case. So this case is a more complex left main bifurcation case. Frankly speaking, we also assigned this patient to the fate main trial. Unfortunately, this patient assigned to the FFR guided arm. Anyway, I will briefly introduce our team, Dr. Wee, Dr. Che. Dr. Che will introduce our patient, the clinical history and information. Could you please?
Thank you. Thank you for introducing. My name is Hyung-Woo Choi from Asan Medical Center, third grade fellowship, cardiology. And let me introduce the interesting case. It's my pleasure. The 74-year-old male underwent PCI at OM branch at another hospital due to exertional chest pain. And he was referred to our outpatient clinic for further evaluation, and the additional coronary intervention was planned. As you see, previous PCI on December 30th, 2025, and came to our outpatient clinic. He underwent cadaveric liver transplantation in 2012, and he had no other risk factor of like previous MI or other diabetes, hypertension, or dyslipidemia. And his chest X-ray showed no cardiomegaly or no other pulmonary edema or other specific findings. And we didn't get to have his other non-invasive studies like echocardiography or treadmill thallium or other tests. And we tested his coronary angiography just today. And these are our plans for today. And let us show you the coronary angiogram. Thank you.
So thank you, Dr. Che. So could you show us that the coronary angiogram today? Yes, this is the left main bifurcation case, AP quarter. Next, please. Patient definitely complained of effort-related chest pain. Aerial caudal view, very tight, left main bifurcation. Aerial cranial view, this left main. With LAD, some intermediate stenosis, but today's procedure, I don't care with LAD stenosis. I focused on the left main. After finishing the left main procedure, I will consider the with LAD evaluation. So spider view, you can see the previously implanted stent in the OM branch. But after the OM branch implantation, patient suffered from the effort angina, so patient visited our outpatient clinic. This is the first angiogram in my hospital. So definitely this is a left main bifurcation case. So I told you before that this patient assigned to the fate main trial, the FFR. Yeah, definitely I think FFR is lower than 0.8. Oh, could you show us that FFR, LAD FFR first?
All right. This is FFR arm.
All right.
So LAD FFR is 0.55. So interesting finding is the pressure drop is very minimal. So I think this left main is so tight, so the further pressure drop doesn't occur. So could you show us the circumflex FFR as well?
Circumflex FFR 0.63, right?
Yeah, to the OM branches, so 0.63. Definitely both branches, the FFR is very low. So considering the contemporary cutoff value and the traditional cutoff value, FFR 0.5, 0.63 is a big deal, very tight stenosis. So this is spider view. So do you have any comment or?
I've got to ask is if the do these findings with FFR tell you that you have to treat the circumflex or not? Because it seems like your FFR may be determined by the left main.
Yes, right, correct. So for the study purpose, I measured the circumflex FFR. Actually, practically, we don't need to measure the circumflex FFR in this case. So,
I mean, you could remeasure it after you treat the LAD if you wanted, but I think it's, I mean, it's
Yeah,
going to be
yeah,
very
right.
tough not to treat that circumflex. I think Dr. Taggart, though, is having angina. I'm quite sure.
I mean, these targets are even better than the previous targets.
So what would you do there, Dr. Ahn?
so yes, we evaluated IVUS. IVUS is actually very important for left main. Unfortunately, Optima trial failed to show the benefit of IVUS guidance in left main treatment, but still, I do believe that something in the IVUS evaluation. Please show us that after we already inserted the wire, and then we did the IVUS evaluation. Could you show us the IVUS from the LED pullback first? So here is the LED pullback previous. LED pullback. So this is LED pullback. Prox LED. Large lumen, large vessel, almost 4O, huge plaque. Very different from
Very
the,
tight.
this is a very ostium of circumflex. This left main. Left main is very huge. Ostium, very mild plaque. Could you show us the circumflex?
Can we just look quickly at the ostium of the LED again, just for
Could
one
you show us the
second?
ostium of LED? LED ostium. 조금
So,
더,
and then,
더
okay, fine. Now
proximal.
go more.
더
If
proximal.
you can show us the ostium of the LED and just do the pullback, please. So that's the ostium of the LED.
Stop.
Here's the circumflex that comes in at 6 o'clock. Keep playing, please. Keep playing, please.
Play.
Okay, and that's the left main. All right. So,
Yeah.
large non-calcific plaque burden, distal left main, straddling the circumflex into the ostium of the LED, probably a little worse in the ostium of the LED than distal left main.
Yeah,
And
right,
big
correct.
vessels, both, and little or no calcium.
Yes, positive. Yes, very no calcium. So could you show us the circumflex pullback?
Circum. 30,
This is circumflex. 30 over 35.
Constriction.
Okay, some OM branch. First OM branch. Here is the ostium of circumflex.
Right.
Pretty
you show
much
us
plaque.
again?
Right.
So you see
Large
huge
plaque.
plaque burden in the ostium of the circumflex. There's the LED coming in at 2 o'clock. Okay. And if you play a little
So
bit
the
more, you'll see.
ostium of circumflex, circumflex size is about the 4O.
And again,
Huge difference between the
No, no, it's-
angiogram and IVUS
right,
finding.
so here's a circumstance where the blue line is not accurately reflecting the vessel size.
Correct.
That's why you must have oversight. But again, the
Yeah,
ostium of the
correct.
circumflex has a large plaque burden, little or no calcium.
So
Yeah. So this is very different from the first live case. Live case, very calcified left main disease. This patient very tight, but mostly soft plaque, not non-calcified, huge plaque burden. So how to deal with, how to treat it? Could you give us some advice or your comment? Circumflex, how to treat it, circumflex?
And I don't see any way you're going to get away without 2 stents again. I think you're going to
Agree, totally agree.
I think you're going to, despite the fact that it's different anatomy, I think you're going to be treating it the same.
For balloon.
Can I
You can
suggest
crush
that
up the distal left main into the.
Does that decision have to be made now or after?
just to be
pre-treating?
provocative, has the
You
IVUS
could.
really told us anything? I mean, if you look at it, you can see there's no calcium. You know that you're going to use 2 stents, really, when you look at it, because that intermediate is there. And the IVUS is helpful, but it hasn't really changed my strategy. You know, I'm going to use 2 stents. I want to make sure the intermediate's open, and I want to make sure I get a great result in the LAD. I'm not really sure the IVUS changes that.
So what size do you like to select?
I need something that can give me up to more than 3.5. So I'm going to put at least a 3.5 in the prox circ. I'm going to do the circ first, cross over into LAD, and then use 4O balloons to optimize, and then maybe put a 5 or a 6 in the main. You know, that's what I'm going to do.
Yes, that's true. you are a very experienced operator, so that's why you know already everything about the left main
I wish I did.
Now we
So
understand.
I'm hearing presentations on this from others who say that it makes it's important how the artery looks after you've pre-treated it. So if you treat this circumflex and you end up with what looks like an 8 millimeter or bigger area in the circumflex, 8 or 9 or 10 or something.
With a balloon?
Yeah, with a balloon. What would you do then?
Well, he's got a
This
stent
is
in
the
there, so we're
circumflex.
going to know.
Yes,
I'm
because
going back to without.
I was show that a very soft plaque, no calcification. So without pre-dilatation, I implanted the circ and added is a balloon. So I will do the 2 stent.
Yeah.
Test, please.
He's got a stent already, so you're never going to get that intermediate look, Spencer.
Yeah, I know. I know,
That's your point.
that's my point.
Okay.
Dr. Benning, would you explain the negative result of the recently published the optimal and IBIS CHIP study, which was published in the New England Journal of Medicine? Is a negative result. What is the main reason?
Sorry, I didn't quite get the question.
He wants to know the reason why CHIP, IVIS, and Ultimo were negative studies.
Okay, how long have you got?
16.
So we're going to talk about it this afternoon.
No.
I think there is a variety of possible reasons.
16.
I think in this case,
what's-
I pointed out,
What size, Dr.
Perhaps the
Sripal?
This is a 35.
if you are an experienced
35,
operator and you know what you're going to do,
Giants
the IVIS
stent.
doesn't tell me so much more than I thought.
18.
The points I would make about the optimal trial are, it was a very high syntax
18.
score cohort, nearly 30.
18.
We only treated 1.6 lesions per case with a mean stent length of 50 millimeters, so probably a fairly high rate of incomplete revascularization, and perhaps the pattern of disease elsewhere dictated the number of events. I think there is an algorithm which experienced operators know how to treat left main, and if we're just treating the left main, as I've just illustrated, we kind of know what we're going to do, and we kind of know what we expect to see. And with the angiograms we now have and the stents we now have, we can see when the stent isn't completely expanded, both during expansion of the stent and with high-dose fluoro at the end. So that perhaps mitigates some of the
16.
impact. I'm also going to show some insights this afternoon of some of the analyses that we've done subsequent to the publication that you can't see in the New England Journal of Medicine, which also give us some additional mechanistic insights into why optimal may have been negative. Does that mean I don't use IVIS in my left main practice? No, it doesn't. I still use IVIS. But I think perhaps there are some cases where IVIS tells us a lot, and there are some cases where IVIS perhaps doesn't tell us so much.
Great.
So during your conversation, I already implanted the circumflex stent, 3018 Giants stent, and crushed the circumflex stent ostium. After full dilatation of circumflex stent osteocyte, and then crushed it using the 4O LAD balloon, and I removed the balloon and circumflex system, and then this just after the crush.
LED looks
I will
good.
Yeah, the LED looks
Very
Right.
good. We don't need a stand anymore.
Adrian, just to add on to what you said, if you look at both of these cases, which is probably more true in Asia than we see in the West, there isn't that much diffuse disease.
Right.
The distal targets are great. The IVIS images show that there's extensive lengths that are essentially normal. We don't see this in the U.S.
Right.
But during the daily practice, we have more complex cases. But to prepare the live demonstration, we usually prepare the more discrete, more educational case.
But Gary, I think over time, in the very beginning days of left main at Angioplasty Summit or here, it's even more isolated.
Oh,
But I think now
absolutely.
it's a bit more diffuse, relatively speaking.
But still, when you compare to what we see
Sure.
typically in the U.S., particularly with the elderly patient population.
I think we still don't need to learn how to do this with only one stent. I think we need to figure that out. Because again, we can get these great acute results with 2 stents at the ostium of the circ, and we know that our failure rates are frustrating in that location, and our ability to treat it when it fails is also frustrating. And so, I mean, the drug-coated balloons, I don't know if they're going to replace stents. I know Spencer spent a whole weekend last weekend, I think, talking about that. But it feels like this is a place where I would like to get rid of the stent. Is the ostium of the circumflex.
We don't have any difference between the angel guided and FFR guided. Previous one and these cases. However, for the particular truly bifurcation disease, all right.
4O high pressure balloon. Give us a 4O high pressure balloon. IVUS부터 먼저 보자. So before high pressure ballooning, I like to see the IVUS of LAD for LAD stent optimization. Next step will be the rewire to the circumflex, but before rewiring, LAD stent optimization is more important. LAD is LAD. So after IVUS evaluation, I will do something according to the IVUS finding.
Doctor, there are some disease on the mid portion of LAD, right?
A little bit.
Yes, but left main is more important. So after treating the left main, I will measure the FFR or something to evaluate the mid LAD. Yeah. So here is the distal. Yeah, stent distal looks fine because we selected the stent length based on the IVUS findings. IVUS distal stent should be ranged on the region with the plaque burden less than 50. Okay, here is distal left main. Some malapposed area.
Ostium. Perfect.
Okay. So could you give me the 4O first?
Just for the audience, the stent extends into the aorta by several millimeters, and at the very ostium of the left main, there are areas of malapposition, which has which could create a problem if the patient comes back to the lab. There's no relationship of that and restenosis or stent thrombosis, but if the patient comes back, it's very easy to get the wire behind the stent.
Yeah, that's a good point. So during the first intervention, you do every effort to, as possible you can, to oppose the stent to the left main ostium. 18.
So, Jung-Min, let me ask you a question about the protocol. So if you're going to use FFR to guide this, let's say the FFR in the circumflex is not significant, and then you would not treat the circumflex. If you IVUS, it looks like it has a lesion there. Do you treat it? So maybe explain the protocol. How would you use the FFR?
So actually, left main, we cannot separate it. So physiology, sometimes we need to treat both circumflex and LAD because to avoid procedural complication like the jailed circumflex after simple crossover stenting. So otherwise, I'd like to do the simple crossover.
What is the FFR? What are you supposed to use the FFR for, though? That's the part we're not understanding. Are you using it to optimize? Do you do it at the end to make sure you don't have to expand things further, or is it meant to just indicate which lesions need to be treated up front? How is it used in the study?
So not FFR, based on the imaging. So treated the circumflex.
But you're randomizing to people to FFR or not? So I don't understand where the FFR comes in. What are you doing with the FFR?
So we just measured the FFR to treat or not to treat the left main disease.
So the difference. So if you find an FFR that is over 0.8, you won't treat the left main at all.
Yeah, I think these cases are all very extreme disease, but the idea is that people are treating 50% left mains without physiology, and many of them could probably just be managed medically.
Okay, so that's the goal, is really to identify vessels you don't need to treat at all. Okay, thanks, Bill.
All right, FFR FFR guided means actually we're going to treat or not treat concern is based on the FFR, right? However, IVUS optimization, even in the both arms, we're going to, just...
Yeah, I was just trying to figure out where the FFR fit in, that's all.
Is it also used after, for instance, if you stent left main to LAD, and your question is about the circumflex ostium, is the FFR also?
Yeah, so
okay.
FFR
Help you make a decision whether to do.
totally different, right? If there was a negative FFR of the circumflex stent after the stent crossover, even 80%, 90% stenosis over there, is we want to do the FFR just reveal alone, if negative FFR.
And that's part of this
totally
protocol.
different. Angioguided, there are optional another stent for that, and there's a big difference.
I think you're right, though, Spencer. In this case, I mean, another approach would have been to do a provisional and maybe drug-coated balloon at the ostium of that circ, given how focal and non-calcified that was, and then follow up with physiology. And if the physiology looked good, maybe avoid a second stent.
Well, hard to argue with that.
I like it.
Okay, this is
Perfect.
my procedure so far.
So
The step at the left is the circumflex wiring, and then final kissing balloon dilatation.
Are you going to do final kissing balloon
Sure, sir.
inflation?
Yeah, he said that. Yeah.
No?
Yes, I think.
Not yet. I'm sorry.
Oh, are you going to do that, right?
I'm slow.
So, but if you have a really tight distal left main, your FFR is not help you at all in terms of whether you do circumflex.
Yeah, I fully agree
right,
with it. Yeah, I fully agree with you.
You don't need it then.
I'm a little worried about the big obtuse marginal branches. However, I think it's good, right? The angiography.
What size did you post dilated with,
Three.
Jung-Min? Was that a 5.0 that you posted?
5.0.
Yeah. Okay.
5.0 for left main.
Yeah.
Approximately 4.0.
Yeah, the area where FFR may be most helpful in this case is the mid-LAD and figuring out if that needs treatment.
Yeah. But these patients have not been in any of the FAME studies, right, Bill?
No, we excluded left main.
So I think this FFR arm is really using FFR in sort of a multiple different ways to optimize.
Quite easy.
Right, SJ?
Easy to pass, right?
Yeah, it seems, I mean, again, some of it's making decisions up front, some of it is making decisions after.
Right, so if the circumflex looks a little tight here, the FFR here may help you decide, I mean, not just stand one, but multiple places.
Yeah. I mean, it's a little bit like the defined GPS study that Alan Jeremias and Greg Stone led, where they're trying to use, in that case, IFR with co-registration to optimize both where you stent and then how you stent.
So we're seeing the crush technique, and I think one of the values of the crush technique is that you probably, when doing it routinely, are more likely to get a good result in the ostium of the circumflex than you are with a clot. I think sometimes with a clot, you don't emphasize enough the ostium of the circ because you're too busy thinking about the LAD and the recross. We saw in the first case, Dr. Yeung Kang go back with a new balloon, stop breaking the sequence of the crush to make sure the ostium of the circ was properly expanded. I'd also point out he did that without IVUS. He knew, because of the angiogram, that that needed to be done. But we know that the ostium of the circ is the weak point, and that's what's got to be prioritized. And we're seeing that with the distal cross, with the wire, and now sequential inflation, and then the KISS to make sure that both those stents with the two-stent technique are fully expanded.
I wonder about the use of the FFR in case you did use one stent technique to LAD, and you dilated the circ and you got an angiographic good look, and you're one of the ones who decided that the drug-coated balloon might be used. It seemed like there the FFR
I think
would play a major role in
high pressure balloon.
telling you that that's a bad idea. You still need a stent. Yeah.
It seems like it. So we have to go back to
So
basics.
this is a small balloon. This is a small balloon. So I inserted the larger balloon, high pressure balloon, 3.5. So LAD is 4.0 high pressure balloon. Circumflex is 3.5 high pressure balloon. And then I will do the final kissing balloon dilatation. And we'll show you and finish my procedure after the IVUS evaluation.
So sequential inflation, then kissing inflation?
Yes.
First the sequential, and then final kissing.
Spencer, as
To
you,
achieve the-
as you suggested, anyway, the circumflex ostium is not usually do the stent procedure, right? In some cases, we want to think about the balloon force, short lesion length, big artery, balloon force, and then main stent crossover, some drug-eluting balloon, something like that. However, we believe for the particular disease study, big vessel, left main, upfront two stent would be good, based on our data, right?
20.
So there is another. However, in the practice concern, we're going to do that, right?
But you're the one who
20,
taught us that one
high pressure
stent
balloon.
years ago, but you
Inflation.
switched.
This is a 4O high pressure balloon. 20. Deflation. So both 10, 10, and 10.
Good. I like it. Oh,
1, 2, 3. So it takes only the 30 minutes to finish the left main bifurcation stenting. So if you know how to do it, even in the live demonstration, you can finish your procedure within the 1 hour.
okay.
So
Would you show us angiographic findings as of quite limited time?
just a
Great.
moment. Ready? Full angio. Okay.
Good. Big arteries, looks good.
Yes.
Maybe-
Actually, we reconstruct the left main
Enough stem.
bifurcation.
So as a
using-
next
yeah.
step, what would you do, Dr. Ahn? You want to do the FFR for the LAD? For the
Yes,
for,
to
yeah,
not
with the
to treat
LAD
it,
region
to-
evaluation,
yeah.
something
Yeah.
like that. Okay.
Yeah.
Dr. Ahn, great. Really great cases. We want to do the next room. So thank you for.
Thank you.
Okay. Dr. Kang, can you hear me?
Yes, I can hear you.
Great. Oh,
We did the two stand
almost same
and
finding.
actually finished the double kissing minus. Yeah, minus with a 3.5
Oh,
and 3.25.
okay, finally kissing balloon
And
inflation.
next?
Right?
Yeah. And actually the imaging shows that the angel finding is very good. But when I checked the IVUS, I found that some carina intrusion to LAD
Perfect.
from circumflex side to left main. So
Lamb's branches has some hesitancy. However, flow is good.
yeah, I think it's similar between the pre and post. Yeah.
David, this is last stop.
So-
What do you think about the two cases?
I think both cases would have been very good for bypass grafting, but I do accept these early results look excellent. But I also point to Dr. Park's own data showing that one of the greatest predictors for need for subsequent revascularization is bifurcation disease. So early results great, longer term, wait and see.
And plus the event rate of a patient who presents with left main restenosis is high both acutely and over the next 5 years.
Yes.
Whether treated with surgery or angioplasty.
I continue to think that we need to figure. I mean, again, we learned how to do these with one stent from SJ many years ago. We need to figure out how to do these with one stent and a drug-eluting balloon. I mean, I think, I feel like that. I hope that really is a solution, and then we can really get Dr. Taggart to his retirement. I think that stage.
Procedure-wise is quite, not too much different. However, FFR guided in case of a multi-vessel disease, we want to evaluate the other vessel, and compromised size branches, we want to do the FFR, and so that makes a small, a difference between the two. So, okay, Dr. Kang, it's really great cases. Thank you for, right?
Thank you so much.
Yeah.
Thank you very much.